Well, dear viewers, we will be talking today about pharmacotherapy of influenza, its common flu, and then the rhinoviruses, and of course the coronaviruses in perspective of the novel COVID-19 that have been reported this in the beginning of this year or late in the 2019. Uh, my presentation will include the virology, epidemiology, clinical features, and of course, some points related to diagnosis and treatment and preventions in general perspectives. Regarding backgrounds, so for virology is concerned, as influenza is on the top, and that is 10 to 15% of the population usually are infected in particular seasons where type A and B viruses are very much common in human beings, and there is of course type C, but that's not common in the humans. Then the avians or the birds origin influenza virus, of course, that is there. Then respiratory sensitive viruses and parainfluenza virus, of course, human metapneumoviruses, rhino and coronaviruses, which cause this pandemic these days, and the whole world is in problems. And of course, there is a severe clinical condition being arised by severe acute respiratory syndrome due to the novel coronaviruses. And then the hantaviruses are there, adenoviruses are there. But so we will be merely focusing on these two because these two are the really problem of this day-to-day pandemic, especially globally in this particular situation. It is spread from person to person, and then from in shape of fomites or aerosols. Once an infected person sneeze or cough, you see, so the droplets that are released in shape of aerosol to the atmosphere, and the nearby persons then inhale it to the nasopharynx, and then it goes to the lungs and then infect that nasopharynx and in the respiratory tract, you can say. So usually the upper respiratory tract signs and symptoms are very common in the first week, and then it goes. So direct person to person contacts there, and usually lockdown theory is very important, because most of the infections are of community acquired respiratory tract infections, but nosocomial infection may occur, and this is very important, especially once health professionals are there in the hospitals, and one should be quite, the epidemiologists must be quite vigilant about this as well. What is important so far, the viral structures are concerned. This is virus envelopes, and in this envelope you can see there are certain antigens with a particular amino acid sequence, and then the neuroaminoidase enzyme, and this surface antigens, you see, then the antibodies come and attach with this one. So what is important? Important is the internal is the genetics materials, and this genetic material, you can say, can be sometime mixed once it is crossed. So far the Mendel's law independent assortment lies concerned. So what is important? Important is that if there is small changes in the surface epitopes, this is called epitope of antigen, then it is called as antigenic what you can say, antigenic shift. This is a small change, and if there is a antigenic drift, and if there is a major change, then it is called as antigenic shift. So important is because usually there is a Y-shaped antibody, and you see, and Y-shaped antibodies, there are some sites are there, and this particular site is the paratope. This particular type region is paratope, and this paratope is usually coming and helping attaching with the, what you can say, this antigen. So the paratope site is there on this antibody, you see, and the antigen is having an epitope, and small changes in this may lead to failure of the vaccination, you see. So and that is why once one virus gets gets changed, what you can say, in its shapes and its genotypes are there, so then different serotypes are there, and different serotypes then can create problems for in the vaccination. So what is important? Important is that while preparing vaccines, one should be quite vigilant about the antigenic drift. That means the small changes, and then the antigenic shift, which is a major change. So a vaccine prepared today may not work in the coming year because of these possible changes in the surface epitopes of the, and of course of these viruses. This slide shows you the history that the first Spanish influenza was reported in 1918, and remember there were eight genetic segments were there. This is 1, 2, 3, 4, 5, 6, 7, 8. 8 genetic segments were there, and this was that the cause was that it's from birds, it's been to the humans, and this is a particular origins. And the surface it has neuraminidase, which is a particular enzymes that is also called sometime silase enzymes, which causes the hydrolysis of glycosides, or sometimes called as glycosidic hydrolase enzymes, that cleaves the glycosidic linkage of the neuramidic acids, especially of the viral neuraminidase enzymes, because this viral neuraminidase enzymes are frequently used for the antigenic determinants, and thus subsequently we determine the relative virulence of a particular virus and is the antigenic traps or shapes. So what is important? This neuraminidase enzyme then helps in the release of the viron from the recipient cells, and thus if we inhibit this neuraminidase enzyme, it means we can inhibit the replication of the viruses as well. So the beginning was in 1918, this was two. Then the second pandemic was in 1957, that is called Asian influenza. And important is the similar structure was one crossed with H2N2 type, the avian birds this time. Avian mean birds. So it led to a variant particularly it contains 5 RNA segments from 1918. You see, and this blue one, first, second, third, and fourth and fifth. So this 5 RNA was from this blue one. These 5 blue are from this one. So what does it mean? These 5 blues are from this one, and these 3, what you can say, are from these 3s are from, what you can say, this one. So complementary, the Mendel law of independent assortment applies, and it's went on subsequently. Then in 1968 there was Hong Kong influenza, and this was H3N3 influenza, and similarly this one was the human virus H1N1 was then crossed with the, what you can say, no matter whatever the reason was, with the avian virus H3. Subsequently then it led to two genetic segments from the avian influenza. You see, this was H3 and then was H2N2, the avian influenza. So this one and this one, and then plus the human virus segment were also there. So one can say that from the 1918, 5 RNA strands were, or segment were here. This is 1, 2, 3, 4, and 5, and these yellow and the red one are from the avians, what you can say, um, carriers. So, and then the next generation pandemic was awaited, and then of course H3N2 and the avian wars that may lead to which particular type. But some people say that severe acute respiratory syndrome novel virus they named here, and that was perhaps reported in the year 2002, if I'm not wrong. So what is important to understand is that there are persistent changes and there are the different pandemics era 1918, 1957 and then 1968 and now recently there is the recent pandemic that is with the novel uh, mm, uh, COVID-19 virus, you see, pandemic that started late in the year 2019, originated from the Chinese province. So this is understandable that in futures there can be different variations in the and all these things are based on these surface epitopes, you see, and you see all these things are changed consequently this may lead to antigenic drift or antigenic shift, and this is the reason that different serotypes then exist, and these serotypes, so you may have a vaccine from 4 serotypes and that may not work up to 2 or 3 years because of this particular subsequently cross changing or through the Mendel law of independent assortment law is applied here. Some incubation period is there and details for pharmacotherapy. So we first targeted the influenza, and you see the first 2-3 days are very important, and it usually affects the children. That is important, and the illness is especially children's or kids below 2 years are at much more risk, and patients who are already having COPD or corporal disease or immunocompromised, they are at much more risk. Onset of symptoms is abrupt, but it is an important point to understand. 90% of the cases have dry and non-productive cough with nasal congestion, rhinorrhea, headache, sore throat, myalgia, as usually come across within common flu. But regarding pharmacotherapy, the amantadine and amantadine, but resistance have been developed in the M2 channels, especially the proteins that is present in the viral envelope. So these its uses are nowadays not so much encouraged. Of course, neuroamylase inhibitors are opted, and they are utilized, used in different doses. So far, the severity of the infection is concerned, plus supportive therapy is there. So this is just for common flu, which usually remember the sensitivity of the kids is 40 to 80%, where the RT-PCR reverse transcriptase polymerase chain reaction is more sensitive. This is a technical point to understand because it will help us once we proceed. So far, the different serotypes is our concern. In case of coronavirus, you see there are 3 different genera, and these 3 different genera, these can infect the humans and of course the animals and then the birds as well. And these birds and the humans, and then that lead to the different variants. You see, different variants of the viruses as we discussed in the previous slides. Important to understand is in case of rhinoviruses, you see, it constitutes and contributes 50% of the common colds, and there are almost 100 serotypes. So as I refer to, there are different seras, different serotypes are there. So vaccine are not usually workable because you will prepare vaccine against which particular type of sera, and mean that there is uh, always changes in the surface of your throat. So the antigenic diversity is there, and they are usually from single strand RNA. So rhino, and the season is peak in the fall, early fall, and the spring. So far coronaviruses are concerned, the season is peak in late fall or winter, and and it is in the beginning of the springs. So this current lockdown for further 1 month will, I think, support to get rid of this pandemic, inshallah, in Pakistan very easily. But we need the cooperation of the people. What is important, that the important is that people at risk are who are being infected with the coronaviruses, acute exacerbation of chronic bronchitis and asthma, and there may be acute otitis media as well. Serology is not helpful, as I referred to earlier, but the RT-PCR is very important. We will, as we move on, then we will tell you at which precise moment the RT-PCR will value the sensitivity is 80%, and at which precise moment the sensitivity is less than 80%. But this is a figure to remember, that 15% of the common cold cases are contributed by the coronaviruses, whereas 50% of the cases are being of the common cold are by the rhinoviruses. But these 15% are very dangerous and highly contagious. Both the viruses contribute to more than 50% of the common cold. This is a technical point again to remember. So one shall, while dealing with the rhino or coronaviruses, so think from majority point of view, but so far the pandemic is concerned, then one should be quite vigilant. The symptoms are rhinitis, pharyngitis, sneezing, hoarse, and sinusitis, cough, and rarely it goes to the bronchopneumonia. It may complicate in a particular situation, especially if the COPD and the cardiopulmonary diseases are immunocompromised patients you come across simultaneously with these situations. The best thing is that these infections are self-limiting. Keep this point in mind. These infections are self-limiting. But the worst thing is that a single case can cause a pandemic. Thus, lockdown is very important, especially where you will do the lockdown first from the schools, from the daycares, then the family members, and of course the businesses. I'm very worried about this current lockdown because most of the family members are not focusing on this point, that family members should confine themselves to a particular distance, even if they are in their homes. Of course, that is important. And though the business centers are closed and then the schools are closed, but this is a point to remember, especially once we are in our home. Severe acute respiratory syndrome related novel coronaviruses, so far they are concerned. You see, the latest one, that is novel COVID-19 is there, but before that the SARS-CoV was the terminology was kind, and that leads to the 50% of the common cold cases by the rhinoviruses and 15% by the coronavirus, as we talked about in the previous slide. And patient at risk are COPDs, and in children these coronavirus may cause acute otitis media. Important point to understand is that the incubation period is 2 to 14 days with a mean 5 days, you see, and the infectivity is maximum on the second week, where the viral load is at its peak. And this is a point to understand that on the second week the infectivity is very high. Single case can trigger a pandemic, and therefore strict public health requirements are very important. The novel human coronavirus, you see, etiology is not related to humans, though, or animals coronaviruses, but yet it is exhibited 99.8% homology with with the severe acute respiratory syndrome like coronavirus found in the animal market of the Chinese. So exotic animals are the sources like parrots, etc. And one should take care of all these particular. So far symptoms are concerned, as I said, there is chills, malaise, fatigue, and headache. So in nutshell, once you will be dealing with that clinical feature and diagnosis. So as I refer to, there is malaise. The technical point to remember is that there is fever in 95% of the case. Fever is there. In the early timings of the infections, there is an increased level of the CK level is increased, then the LDH level is increased, there may be lymphopenia. During the first few days, respiratory signs are usually absent and chest radiograph may be normal, but on day 7th and from to day 10th, the respiratory symptoms get worsens, and some of the patient, more 20% of the patient may require supportive on support on ventilator, and once the patient goes on to ventilator, then the mortality rate is 50%. Usually on second and third week, the illness, the patient recovers spontaneously. This is a technical point to remember. So as I referred in the previous slide that they are self-limiting. Atypical representation of is there that there may be no respiratory symptoms when the patient may come with diarrhea and fever as well. So the clinician should keep in mind this if there is a pandemic and you may come across with a case like this, so you should take care of this. Go for the antiviral therapy. Now, in case of diagnosis, the technical point is that travel history is important of the suspected person, and then the occupational therapy. You see the health of that person. For example, a person working in the wildlife that may come across with parrots, or that may work as a reservoir for that. So a ride history is important, and traveling history is important, occupational history is important, and then the nasal aspirate and the respiratory secretion. So you see I refer to on the second week, especially 9th and 12th day, the RT-PCR sensitivity is 80%, and keep in mind 50% in the earlier than the 9th day, the sensitivity may be less than 50% or in the later time. So the peak time, one should keep in mind what is the peak time, and the peak time is the beginning of the second week, you see. So where the viral load is very high and you may come across with so the sensitivity of RT-PCR is 80%. So keep in mind it's not 100% the RT-PCR, and a person still may be a carrier. This is a technical point again to remember. In serological tests, antibody response is good, but some people sometimes kind the idea that those patients who have been recovered, let we take their plasma cells and then incorporate inject that to the severely affected person. So they are called convalescent sera, and convalescent sera may be helpful, especially. But again, time is very important. 90% of the convalescent sera loses its what you can say antibody status if you got less than 28 days, and 50% is on the day 5th of the convalescence period. You see. So there is zero conversion, and this zero conversion is very important, especially in a country like Pakistan, when you will be searching for patients and going for the looking for the convalescent plasma, then isolation there, and then so it may take certain times, and you may not get the immunocompetent, what you can say immunocompetent, or the real competent convalescent plasma that may help the patient who are in trouble already on severe acute respiratory syndrome or in respiratory distress. with their need. Though this mode of therapy is still not approved from the FDA, yet the people are coming this idea. Regarding the treatment, of course, since it's a case of acute respiratory syndrome, so very rare intubation is required. There may be patient is on ventilation and supportive therapy, antiviral therapy, corticosteroid, interferon, and that is usually Infectious, though the efficacy is question. Why the efficacy is question? As I referred to in the previous slide, that 50% of the worsened case goes to have poor prognosis, or the consequence as a death is there. So one should keep in mind. Then the treatment, of course, is very important, and prevention. Chloroquine and azithromycin combination is being tried these days, but let we look forward for that, the result of that, because in case of new drug development, there are preclinical phase, there is a clinical phase, and let me refresh your knowledge. In the preclinical phase, usually that is happening in the animals, and then there is toxicity study or toxicokinetics, and then pharmacological action, pharmacokinetics and dosimetry is there. And very interestingly, you see, then in the clinical phases, we go to the what you can say confirmatory pharmacology and the clinical trials, phase 1, 2, phase 3, and phase 4 clinical trials. You see, so this is called translational medicine, that we translate the results of this basic medical sciences in the clinical sciences. This translational medicine concept is very poor in Pakistan, and now we are facing problems. Rather, the whole world is facing problems. So now new molecules are usually tested through this. They're passing through this phase, and then it goes to the clinical phase. There may be an old molecule. This is an important point. You may come across with an old tested molecule, and that old tested molecule may be tested in the new indications. But remember, for new molecule, you have to perform acute studies, toxicological studies, and that chronic toxicological study and subacute study. These are all mandatory for new molecules. But in case of old molecule, so these are not required. And then what is important? Then you see the new drug development phase is the synthesis and examination of molecules, and then 10 to 20 molecules from these 1,000 folds goes to phase 1 and phase 2 and phase 3 clinical trials, subsequently leading to one molecule being flooded into the market, and this is called as a new drug development. But this may take almost 12 years, and in this pandemic we cannot wait now for 12 years. We need an urgent drugs to support that. So this is a study. This was a letter to the editor from the Springer Nature, and where the chloroquine has been tried. You see, and this is the immunohistochemistry, and these fluorescence crops are there, and this is the chloroquine concentration at 1.1 micromolar and 3.3 micromolar and 10 micromolar. Now look at this. This is DMSO standard, and you see, and it rarely affects at 1.1 micromolar, but at 3.3 micromolar, still the response is very good versus this negative control. You see, you can compare these two. So these mild greens are there, and on 10 micromolar is real inhibitions of all what you can say the viral cells replications. Interesting is that remdesivir is also very potent. So these two molecules have been found against and tested against the novel this coronavirus infectious disease is being reported in the year 2019. This is an in vitro study, And remember, an in vitro studies, you see, in vitro study requires they are usually killed here in this particular phase, and this should be translated in the clinical phase. And translating all these studies in the clinical phase still require the expertise. So what is important? Important is to translate the effect of this study, chloroquine, that is effective in what you can say 10 micromolar. And 10 micromolar, this keep this point in your mind, because there is full clarity, and as 11.1 micromolar of remdesivir, you can see the effect are as like this one. So these effects are comparable. Now translating this, so I just Google and perform another literature study, the pharmacokinetics of chloroquine and some of its metabolites in healthy volunteer following a single dose, because we should go for a single dose, and the single dose was given at 300 milligram chloroquine per oral route on 24-hour fasting, which is not mentioned here, but I have written here for your easy understand. And this is the point. You see the CP maximum concentration is in this case is 402.9. This is the mean plus minus standard deviation. And if you see, once drug is given through the oral route, so it follows this pathway. It is then absorbed, and this is the CP maximum. You see, this is the C maximum. Mean C maximum is here. This is plasma concentration. Concentration is on y-axis, and then what you can say, time is on x-axis. So time is on x-axis, and this is the Tmax, and the 50% that goes to the half-life. This is the half-life. So this is the half-life, and this is the Tmax. This is Tmax, and I'm interested in this, that this particular point, this value is important. This value is this one, and once we converted these values, this is nanogram per ml, and this nanogram per ml is then converted into 402 microgram per ml. You see, so if it is microgram per liter, this will be microgram per liter. Sorry, this is microgram per liter, and this is microgram per liter, mean the unit is from nanogram to microgram, and this is 402.9 microgram per liter. Now this 402 microgram per liter, you see, is then converted into micromolar. So if you convert this into micromole, so this is 0.7801 micromole per liter, and micromole per liter is the unit is micromolar. And if I carry you back to that slides, so here is the 10 micromolar, the real clarity, complete inhibition of this, what you can say, for remdesivir, that's complete as with the chloroquine. So the complete clarity is there, but this is 10 micromolar, and so far this is concerned this a single dose follow-up, and in the case of single dose follow-up following 300 milligram chloroquine on a fasting 24-hour fasting, so it gives you the mean peak concentration with 0.780 micromolar. So this is still below that particular clarity points what is reported with this one. So what message I want to give you to the clinician? The message is that still we have to work hard and optimize the dose of the chloroquine or hydroxychloroquine so that we can go on to the realistic results and translate them in real clinical trials. If people gives these drugs, so one should try this with logic. Uh, and a clinical trial definition given by the dreadful that is a carefully and ethically designed human experiments with answering some precisely framed question. This definition was coined in 1966, perhaps, and still valid. So plasma, what are the therapy modes? Are there plasma, convalescent plasma serum is there, and then that you can see we have the option of chloroquine. That's still that needs to be translated in clinical practices, and it needs still FDA approval. Drug is still not approved from the FDA because last night or rather evening, as a member of the American College of Clinical Pharmacy, once we were on a webinar together, all members. So there was FDA member was there, and they said still not a single drug has been approved for the coronavirus by the FDA, and still we still hopes that though they have the fund, the vendors or the pharmaceutical companies are going to support them, but yet the scientist has to work very hard. Probably the coronavirus infection are self-limiting. Yes, they are highly contagious, and due to this antigenic drip or shift, whether that is experimentally or by incidentally, so that can create problem and for the society in perspective of the clinical features. So yes, still we have no other choice given antiviral drugs and immunomodulator drugs. In summary, we appreciate the government of Pakistan efforts to take strict isolation measures. Lockdown, we should support the government, and lockdown should be in perspective of that even the family members shall take care of unnecessary gathering while living within their homes, and they should take about their hygienics. About healthcare professionals, they can infect their family members, and the pharmacotherapy is supportive. Still, no vaccines are available there, but the people should cooperate with the government to curb it. Remember, on that almost in 21 days, uh, this the whole that incubation and then the recovery that is, and the end is complete of this disease nature. So 3 weeks lockdown, perfect lockdown, self lockdown is very important, so that this should be stopped and further not uh, prevail, because if every home is affected, then there are immunocompromised patients and there are weak patients, and then they may come across with severe illnesses and SARS, severe acute respiratory syndrome, and that can be catastrophic. There is a need for promotion of translational medicine in Pakistan through a joint venture of pharmacy and medicine disciplines, as it is in the United States of America, and I'm being a member of the American College of Clinical Pharmacy and Clinical Pharmacology, and member of the academic education committee. So that time has come now, because on Facebook I can really see that they say that Higher Education Commission gives this much money, and still we don't have. I'm just telling them that, my dear, the whole world is facing this problem, and probably since these infections were self-limiting, so the scientists were never bothered by these. Since now the emergence of novel strains, as I reported in the previous slides, so then I think this is the time to understand that further scientific work is required so far translation medicine concerned. Before going to the references, let me tell you another very important point is that if this is long, and then this is, you see, this is purely diagrammatic, and then there is alveolar sacs are there. And then there is the what you can say the epithelial linings are there. And these are the epithelial cells lining, and if the epithelial cell linings are there, so the drug's concentration in the epithelial fluid is important. So one can study this in the epithelial fluid. This is a typical point. Epithelial fluid on the concentration of drug one shall test. This chloroquine shall be tested in perspective of this point. Second, the second important point is that the alveolar macrophages concentration should be tested. Alveolar macrophage or cellular extracellular ratio of. We are going to give this target to one of our MPhil students, but since the university is closed, so these two parameters will tell us the behavior of chloroquine prospectively, or any other from the Swiss target prediction model will tell us that what will be the fate of chloroquine in future perspective. So far, its pharmacokinetics. It's not the plasma level. Remember, the plasma level. It's now people are looking beyond plasma level and reaching the drug at the site of infection. So epithelial lining fluid concentration is very important. These are references, and I hope you have got some points regarding that. Thank you.